For joining us. I'm Jonathan Kaplan, board-certified plastic surgeon in San Francisco and also the founder of DrWell. We appreciate this amazing reception of registrants. We had 316 of you register, and before you ask, you will all get a recording of the webinar, whether you attended or not, but you will get a recording. We certainly want you to stay tuned and not wait for the recording, because we really want you all to ask lots and lots of questions. If you look over on the right-hand side of your screen on the GoToWebinar control panel, you'll be able to ask questions throughout, and I cannot emphasize enough, ask questions. Please ask questions for DrWell, for myself, for Jennifer Cooper, who's our Chief Nursing Officer of DrWell, and then also Katya Black, who's with MedBio Institute. We've really enjoyed working with them as partners. They're a great resource. And with that, I would love for Katya, please explain what MedBio Institute does and why y'all are such a pivotal resource for anybody in the weight and wellness space.
Yeah, thank you so much for having us. Yes, I'm Katya Black. I'm one of the founders of MedBio. And we launched this platform last year because we wanted to create a centralized place where clinicians can come and learn about new products, new modalities, learn about peptides, learn about what's changing in the industry, and have it be kind of like a centralized place, for all different types of resources, kind of within the regenerative medicine longevity space. And we do partnerships and offer free webinars with a variety of different partners, including DrWell. We are offering courses. We had our first one last fall on perimenopause. We're actually launching a second session of it coming up. But kind of a wide range of things. And we also do individual consulting for clinics. So whether you're looking to launch a clinic, or if you have a brick and mortar location, you want a telemedicine platform for help with marketing, AI automation. We have really deep expertise within that space. Yeah, it's great to be here with everyone today.
Well, thank you for joining, and we'll be doing additional events in person and online with MedBio Institute in the years to come, so stay tuned for that. But thank you again, Katya, for being here. And before we hand it over to Jennifer Cooper, our Chief Nursing Officer of DrWell, also known as Coop, I want to explain what DrWell does. And so for those of you who might be new, but DrWell, if you look at this flow chart, it shows some comparisons. If you think of Roe or Hims, they've made it very easy for consumers to get access to medication, which is great. Patients can fill out an asynchronous consultation, which is like an online questionnaire. And in most states, 31 states, that's really all you need for a patient to fill out so that you can then legally pass on a medication to them. The only thing is, with Roe and Hims, they hire a bunch of independent contractors. Some of you on this call may be independent contractors that work with them. And the thing is that they dot the I's and cross the T's to legally provide a patient with a prescription. But the thing is, when a patient signs up for that medication prescription through Roe or Hims, their relationship is with a website. If they ever need any assistance, they reach back out to Roe or Hims. They're going to be passed along to a different provider. You're never going to ever see the same provider. And Roe and Hims have like $1 million budgets for advertising. So you as a provider, you may be thinking of that person down the street as being your competitor, but no, your competitor is the Roes and the Hims. That's who patients are going to, because they've found an easier way to get access to medication. So what DrWell does is we allow you, whether it's your brick and mortar or telehealth clinic, we allow you to compete with the likes of Roe and Hims to get access to those patients who are looking for an easy way to access medications legally. So with the DrWell tech stack, we offer DrWell Smart Consults, which is the same thing as an asynchronous consultation or an online questionnaire. And this is just one way. This is talking about the patients that are looking for you online, that they can get access to you, and that we host all of that for you. Then after they sign up, we process their prescription through a high-risk payment processor, which then generates a prescription in the back end of the DrWell platform. So you can then submit that prescription, and it's electronically routed to a compounding pharmacy. So you don't have to look for the compounding pharmacy. You're not going to get a good as rate as we can get for you, because we're ordering on behalf of all of our providers. So we're getting these bulk volume discounts. And so you can just be able to compete with the Roes and the Hims with your in-office patients. I want to be very clear. We're not just offering you this smart consult for telehealth and online. That's one aspect. But even for your in-office patients, it's very easy for them to enroll in a medication through the DrWell platform. It's got white labeled for you. And so they can, then again, you're making this easy for for patients. You're not having to go and develop this technology all yourself. And then you can order medications for your patients through DrWell, either for in-office or online patients. And then those medications can then be delivered to your clinic or to the patient's home. Similarly, if you look at the next section, your competition is coming fast and furious from Big Pharma and Trump RX, NovoCare, Lilly Direct. Patients can get medications through them. Again, with the DrWell tech stack, you're now able to compete against them by making this very easy for consumers, either existing in-office patients or online patients, to be able to get access to medication. And then at the bottom, you'll see that DrWell is now in the drug development space that we're working on an investigational new drug application approval from the FDA for our proprietary product GLP-1 squared, which is a combination of semaglutide and tirzepatide. You can only get through us. Semaglutide, tirzepatide in the same vial. It's a lower dose of each when it's combined, and it's been great for weight loss, but also we're seeing patients who are using it for alcohol use disorder and other addictive behaviors. And the fact that it's a lower dose of each, then those patients can truly take this chronically. So it's very exciting what we're doing here at DrWell. And we'll provide you information at the end so you can learn more about getting a demo from DrWell. Also, at the end, you'll have an email address that you can get in touch with Katya at MedBio Institute. So a lot of great information that if you want follow-up, you can get access to us. But with that, now for the meat of our webinar, and again, please ask lots of questions throughout. We'll get to them at the end. I'll pass it over to Coop, who will introduce herself, but also just she's a badass. She's been in the Army. She was stationed in Afghanistan. She escorted Geraldo Rivera around when he told everybody where these secret clandestine bases were located. I think that got him kicked out of Afghanistan very quickly. I think true story. Anyway, but Coop is great. She's a great resource. And for those of you that do come on to become a subscriber to the DrWell platform, not only do you get great rates on medications and easy access to submitting orders to pharmacies and making it easy for your patients to enroll and having those prescriptions automatically charged each month, you'll also have access to Coop. So if you're not heavily involved in running your weight and wellness program, your office staff will always have access to Coop for all of the clinical questions they may have. So it's a really amazing amount of ongoing support with DrWell. But with that, Coop, the floor is yours, and I'm going to turn off my mic and camera so we don't take any of your bandwidth.
Great. Thank you so much. Minor correction. It was Baghdad, not Afghanistan, but that story is true with Geraldo. So without further ado, I'm Coop. I'm the nurse practitioner here at Pacific Heights Plastic Surgery and the CNO of DrWell. So I run our weight loss clinic here. We've got a big panel of patients, a lot of experience. So hit me up with any sort of questions you guys have in regards to the GLPs. But everybody's here to learn more about these other peptides. So this is what we're going to talk about today. Legality. We know that's the #1 thing that people are interested in hearing about. Is this legal? We'll dive into the different peptides that are out there, dosing recommendations, ideal patients, contraindications, and then we'll talk about some ways to bundle or stack those to both maximize your patient's outcome as well as your income on these items. So, are these legal? What is the final say on these peptides? So I'll tell you what's not legal is the research grade, the not for human use, the physician use only. These items are definitely not legal for us to be prescribing. This is a little excerpt from a letter from our general counsel, basically saying, yeah, this is a warning. Don't be prescribing this stuff. It is not approved. It's not okay. And what happens if you do prescribe these things? Oh, well, here's a plea agreement for a physician in Kentucky pleading guilty for using unapproved research grade peptides from a cute little company called Swole AF. So yeah, he got busted for this. He was just ordering these things off the internet, reconstituting them and putting them out there. So yeah, that is not okay. $250,000 fine or 3 years in prison. So don't be this guy. What is okay is sourcing these things from 503A pharmacies, and that's what we do. The 503A pharmacies are all licensed, they're all registered, they follow USP standards, and while they're not directly regulated by the FDA, they are subject to FDA surveillance. So this is the caveat. If you source these correctly, they are no different than any other medication you would get from a compounding pharmacy. So everything we're going to be talking about today is 503A pharmacy sourced, not research grade. BPC 157. This is the first one we're going to talk about here. Lots of buzz around this. What is it? Body Protection Compound 157. This is a regenerative peptide, originally sourced from a gastric protein. We're going to avoid this in a history of cancer, and I'm going to tell you a little bit more about that. What it does, this is a recovery peptide, so it's great for tendon, ligament, nerve, and muscle repair. Promotes angiogenesis. That's why we want to avoid it in cancer. It's not a direct contraindication, but because of that, you know, if it's going to cause extra blood flow, extra blood vessel growth, there's nothing to stop that from also growing a tumor as well. So it's anti-inflammatory. This can help with some of the GI disorders, neuro recovery, joint health, mood, focus. So your ideal patient for this is someone who works out regularly, your gym rats who they want to lift heavy, they want to lift hard, and they don't want to get sore. Anybody who's got an injury, anybody who's post-op, anybody who has chronic inflammation. So basically anyone looking for any of those benefits above is an ideal patient for this. Your most common side effects with most of these peptides is injection site reaction, and that's pretty common. They do tend to burn a little bit, do tend to cause a little bit of redness at the injection site, so that's something to be aware of, something to pass along to your patients. Know that that's normal, it goes away in a day or two. Transient headache, nausea, dizziness, kind of just standard run-of-the-mill things. They're gonna get better. They're not anything serious. This is a sub-Q, so super easy. It's just like your GLP-1s. This one you can do daily, and it's recommended to do it for like 4 to 8 weeks. The idea being, if you're recovering, you're post-op, you have an injury, at the end of the 4 to 8 weeks, you should theoretically be recovered. And with any of the peptides, you really do want to cycle them, really just because it'll help reduce your receptor desensitization that can happen if you use them continuously. So this one, you're looking at doing a sub-Q dose of 15 to 25 units. It's at a concentration of 3 milligrams per ml. It's like a 5 ml vial. So this one you can ship either to your office or direct to the patient. It's stored in the refrigerator, and your cost of goods is around $130 a vial. So this is a great kind of add-on to anybody who's on a GLP, or like I said, anybody who's working out. We've started doing these recovery peptides in PACU. You get your first dose before you go home for all of our post-op patients. TB500, so this one's currently only available in the blends, and we'll get to what the blends are made of, but essentially this is a synthetic fragment of thymosin beta-4, which is an actin-binding protein, facilitates cell movement into the injured tissues. So this really helps to bring the good things to the injured area. So again, we want to avoid this with the history of cancer for the same reasons. It promotes wound healing, tissue regeneration, muscle growth, it's anti-inflammatory, and it recruits stem cells. So again, if you've got a history of cancer, we don't know, there's no studies that say that these initiate or potentiate cancer. So I would say avoid them just out of an abundance of caution. Your ideal patient, again, someone who works out regularly, they have an injury, they have inflammation, or they're post-op. Side effects are, again, your injection site reaction, headache, you can get a little nausea, vomiting with this. It's a sub-Q injection, and the frequency and dose are going to be as part of the blend, so it's dependent on what else it's mixed with. It is shipped to the patient or the office, and this one is also refrigerated. Wolverine blend, this one is, there's also a lot of buzz around this, and that's the combination of the BPC 157 and the TB 500. So it's 1.66 milligrams of BPC 157, 3.3 milligrams of the TB 500 together in a single vial. So it's combining those two peptides to help further promote the healing and recovery aspects. Same patient population, they work out, they have an injury or inflammation, they're post-op. Again, your injection site reaction, transient headache, nausea, dizziness. Sub-Q injection. This one's recommended to do Monday through Friday. Take the weekends off. That way you're doing it 5 injections a week. Take those 2 days off just to help with the receptor desensitization. And again, you want to do it for 4 to 8 weeks. You know, take a month or 2 off, come back on as needed. This is going to be a 15-unit dose. You can ship it to the patient or the office. It's refrigerated, and your cost of goods for this blend is around $136 per vial. Copper. This is a copper tripeptide 1. Copper glycyl histidinol lysine. So it's a protective and regenerative peptide. And this one's at a concentration of 10 milligrams per ml. And this one improves wound healing, stimulates collagen, boosts the immune system, promotes angiogenesis. This one also helps with hair. So the hair and skin aspect is where this one comes in, gives you a little thicker, better hair growth. Same thing with the collagen growth. It's a little bit more towards the anti-aging, antioxidant, anti-inflammatory aspects. So again, anyone who's got an injury, they're post-op, or if they're seeking any of those above benefits. With this one, you can get some skin irritation, can increase your UV sensitivity. So you definitely want to promote the use of sunscreen, can cause a little bit of GI upset. This one comes as a sub-Q, or you can use it topically. Typically, it's either as a blend or in with a couple other ingredients. So there's a few different variations available. But for sub-Q, 2 to 3 times a week injection. Topical, you can use it once daily. The sub-Q dose is typically a 1 milligram, and the topical is a 0.5%. So you can ship this to the patient or the office. It's stored in the refrigerator. Your cost of goods for the injectable is around $128 and around $137 for the topical. And that may vary based on what else is in the topical blend. Glow, this one I love, I'm personally using. This is the blend of 3 peptides. It's the BPC 157 at 1.66 milligrams, the TB 500 3.3, and the copper at 9 milligrams. So it's the combo of all the good things. It promotes healing, increases the collagen and elastin, reduces inflammation, and improves the skin and hair growth. So again, anybody who's working out regularly, has an injury, is post-op, or looking for the above benefits. So I started this myself I started about a week pre-op. I had a foot surgery. I've used it consistently, and I've had great wound healing from it. So I'm a big fan. Injection site reaction, again, pretty common. You can get that redness, a little bit of a welt there. It goes away. Transient headache, nausea, dizziness, some skin irritation, and again, that UV sensitivity. So use that sunscreen with this. This one's sub-Q, and this one's recommended 3 times per week or every other day kind of dosing, again, for 4 to 8 weeks, with the idea that you should be healed up and ready to take a break from it at that point. 15-unit dose, you can ship it to the patient or the office. It's stored in the refrigerator. Your cost of goods is around $136 per vial. CJC 1295 and ipamorelin. So this one's a blend of synthetic growth hormone analogs. So it's 1.5 milligrams of the CJC and 2.5. And this one is definitely contraindicated in anyone with a history of cancer. Because it stimulates the pathways that are commonly upregulated in cancer. So the studies show that there's no proof that it initiates cancer, but it can potentiate existing. So basically contraindicated in anyone with a history of it. This one increases the release of growth hormone to assist with your sleep quality, your lean muscle growth, injury recovery, skin quality, and overall vitality and anti-aging. So ideal patients, really anybody without a history of cancer who's looking for any of those benefits. Side effects with this one are going to be injection site reaction, headache, you can get some flushing or kind of warmth feeling, fatigue, a little bit of water retention, and you can get a little bit of an increase in appetite because it does stimulate the ghrelin production a little bit. So if they do start this, they may initially complain of a small weight gain, and that can just be the water retention and or that mild increase in appetite. So this is something that you may want to use in addition to a GLP. It's sub-Q. This is a once daily. You can do that one for 4 to 8 weeks, cycle off of it, and then come back on after a month or so. This one you can do 15 to 25 units, ship it to the patient or your office. It's refrigerated, and your cost of goods is around $123. The sermorelin, so this is a synthetic hormone peptide. It's similar to growth hormone releasing hormone. And this one, again, is going to be contraindicated in anyone with a history of cancer. So it's stimulating growth hormone from the pituitary. This one improves your exercise capacity, helps to increase your muscle strength, your bone and cardiovascular health, can help with some sleep quality, immune function, libido, and skin elasticity. So ideal patients, anyone who works out regularly or looking for any of those benefits, again, as long as they don't have the history of cancer. And your side effects, injection site reaction, headache, flushing, dizziness. This one can cause vivid dreams, so something to mention to your patients so that they have a heads up about it. And again, a little bit of that water retention and some tingling or warmth in the extremities. This one you can give either as a sub-Q injection or a nasal spray. You can do it daily. The sub-Q dosing is 300 to 500 micrograms, and the nasal tends to be 1 spray per nostril. Depending on the pharmacy, it may be 2 sprays per nostril. This is shipped either to the patient or your office, and both routes are stored in the fridge. Cost of goods around $91 for the injectable and around $100 for the nasal. PT141 or bremelanotide. So this one is this one's good for sexual arousal, and it's a melanocyte receptor agonist, and it has a targeted approach. So it causes fewer systemic hormone impacts than something like a Viagra or a hormone replacement. So it enhances the sexual arousal by stimulating the arousal pathway receptors in the brain. So not the periphery, not peripheral vasodilation. You can use this in men or women with sexual dysfunction. And your most common side effects are injection site reaction, nausea, flushing, headache. Less commonly, you can see a little bit of an elevated BP. So you may want to monitor, especially if they already have an existing blood pressure issue. So just something to be aware of. Also skin and gum pigment changes. So you want to use this in caution with anybody that has a history of skin cancer or melanomas, because you may not be, it may not be readily clear if the pigment changes are part of this or are something a little more insidious. So it's recommended they have regular skin screenings by a dermatologist. Your routes here are either sub-Q, the mini troche, or nasal spray. And this one is basically you use as needed, but no more than once in 24 hours and no more than 8 times per month. And so this is something to make sure that they are sticking to that limitation. They're not using this every single day. It is an 8 times per month maximum. Your sub-Q dosing is 1 to 2 milligrams, 30 to 60 minutes prior to your sexual activity. Troche, again, 1 to 2 milligrams, 30 to 60 minutes prior. And the nasal spray, you can do 2 sprays in each nostril 30 minutes prior. So I like to recommend the nasal spray here because it's a little less invasive than, hey babe, let's do our injection together. So, you know, just do a quick little spray, or the troche, same idea, is you can just let that dissolve and then, you know, give it 30 to 60 minutes. So these you can ship to the office or directly to the patient. All of the routes are stored in the refrigerator. Your cost of goods, about $180 for the injectable, $124 for the troches, and about $122 for the nasal. Rapamycin, sirolimus. It's an mTOR inhibitor, so that's the master regulator of cell growth, division, building, and conservation. So basically, this potentially extends lifespan through increased autophagy, cell turnover, it improves your protein and immune function, metabolism, stress resistance. It can improve your cognitive markers, your cancer resistance, and your skin and cardiac aging markers. So ideal patient for this is someone who's 40 plus, looking for anti-aging benefits. But there are a few things to be aware of. It interacts with macrolides, azoles, grapefruit, some calcium channel blockers. So we want to potentially pull some labs at baseline and then maybe keep an eye on those, around 4 to 8 weeks in, and then as needed from there. So side effects here are mouth ulcers, and that tends to be dose dependent. So the higher your dose, the worse the mouth ulcers tend to be. So you can back off based on side effect. GI upset, headache, fatigue, a little bit of edema, acne, hyperlipidemia, insulin resistance, immunosuppression, and some blood changes, and then potential non-infectious pneumonitis. So some kind of weird side effects, and they do tend to be dose dependent. So this is given orally. It's a once a week capsule. You can do it for like 6 months, or you can cycle 3 months on, 1 month off, typically a 6 milligram dose. You can send that to the patient or the office. This one's stored at room temperature, and it's about $115 for 24 capsules. Methyl blue, so we know this as a dye, or as maybe a lymph node marker, vessel marker. So in this case, we're using it as an antioxidant and nootropic. The things to be aware of are contraindications with SSRIs, G6PD deficiency, severe renal impairment. What it does is it's accepting and donating electrons in the mitochondrial electron transport chain. So it's improving your oxygen, reactive oxygen, reduces your reactive oxygen. It crosses the blood-brain barrier to increase neuronal efficiency, and enhances memory, and helps modulate the brain's functional connectivity. And it's also an anti-inflammatory. So this one's a cognitive function type medication. So anybody who's saying they've got brain fog, they're having memory issues, they're looking for anti-aging, neuroprotection, mitochondrial support. That's your ideal patient. Side effects with this: blue urine, stool, saliva, or teeth, mild GI upset, headache, metallic taste, jitteriness, or anxiety. And again, you want to avoid it with the SSRIs, MAOIs, tramadol, St. John's wort, dextromethorphan, and I don't know how to say that one, linezolid. This is an oral one, and you can do this daily or Monday through Friday. 5 milligrams to 25 milligram dosing range. So with this one, you kind of want to start low, see how people tolerate it, move up from there. I would say most common is 25 milligram, but again, adjust as tolerated. You can ship this to the patient or the office. It's room temperature, and your cost of goods is somewhere between $42 and $58 depending on the dose. NAD+. This one, I love promoting this with the GLP-1s because it really helps with the fatigue, exercise tolerance. So nicotinamide adenine dinucleotide, it's a critical intracellular coenzyme. It's in every cell of your body. Improves the mitochondrial energy, helps with DNA repair, cell signaling, helps to activate the sirtuins, which are those longevity genes, helps with the redox balance. It's great for longevity, chronic fatigue, post-viral syndromes like long COVID, neurocognitive optimization. So anybody with fatigue, if they have a high stress job, high stress life, they're having cognitive complaints, brain fog, memory issues, NAD+ is a great option. Your most common side effects here are injection site reaction, flushing, chest tightness. That's something to be aware of. If your patient does not know to expect some transient chest tightness on injection, they think they're having a heart attack and they freak out. So let them know that that is a potential. You can get a little bit of chest tightness, nausea, headache, GI upset, Muscle cramping, again, that's kind of similar to the chest tightness because you're basically providing energy directly to those cells, so you can get a little muscle cramping with it. Anxiety and restlessness. So we got a bunch of different routes that you can give this. Sub-Q, we have flex dose tabs, which are basically little hatched tablets that you can break into quarters, nasal or topical. You can also do IV, depending if you want to do it in a banana bag, something like that. Again, with the sub-Q, it tends to cause the chest tightness a little more than the other routes, so just something to be aware of. This one, you can do it daily, or you can kind of cycle as needed. Your sub-Q common dosing is 25 units. For the oral, it's between 1/4 and 1 tab, and then 1 to 2 sprays per nostril with the nasal. And then the topical is going to be a daily or as needed. These you can ship to the patient or the office, and they're all refrigerated except for the topical. Those, most of the time, you can leave at room temp. But your cost of goods is about $110 for the injectable or the flex dose tablets, and around $120 for the nasal or the topical. So how to best put these things together? You can bundle them. You can do stacks. You can get the tirzepatide, the Hair Force 1, the BPC 157. That's an ideal stack to put together because they're getting the weight loss, they're getting the hair support, they're getting the recovery. Put it all together and boom, you've got a great stack to offer. You can see kind of cost of goods there. Total, and you charge $600, so you're looking at a margin of 55%. So yeah, that people love doing the bundles because it's addressing multiple things in one go. Because the hair loss tends to be fairly common with the weight loss. So throw in that Hair Force 1, throw in the BPC 157. They're feeling good at the gym. They're losing weight. They're keeping their hair. They're happy. And again, these are 503A, and you can only get them through us. So bundling your stacks. So again, these are not commercially available. So the super semaglutide, the GLP-1 squared, super semaglutide is just the higher dosing. So we can go all the way up to 7.2. Normal end of the range is 2.4, but we can go 3.2, 4.2, 5.2, 6.2, 7.2, and up to 17 milligrams of the tirzepatide. So these higher end items you can charge a little more for. So build some packages that have GLPs and the peptides together. We also have microdosing available. So the smaller vials meant for either folks who want to microdose on the regular, or if they're in a maintenance package where they're at their goal weight and they just want to maintain, don't necessarily want to keep up with the current dose that they're on. They want to maybe do every other week type dosing. Those microdosing vials are perfect for that. And again, the GLP-1 squared and the super semaglutide are only available through us. And remember, we've got more than just the GLP-1s. We've got the sexual wellness, we've got hormones, we've got longevity, the peptides, the hair restoration, skincare. So it really is basically an all-in-one. You can get pretty much anything the compounding pharmacies offer at the best prices, get your patients exactly what they need at the dosing that they need. And it really is the best pricing you'll get out of the market. And that's it in a nutshell. I know I threw a ton of information at you. I'd like to thank Katya, MedBio Institute, for helping with this, getting us all together here for this. There's a QR code you can scan to learn more about DrWell. And with that, I will pass it back to Dr. Kaplan to open it up for some questions.
Yeah, thanks so much, Coop. Again, thanks to Katya and MedBio Institute for being here with us. The QR code, which will take you to a page where you can request a demo. On that page also is a calculator where you can actually use, you can type in what you want to charge for semaglutide or tirzepatide, and then it will show you how quickly, based on our low cost of goods, how quickly you can actually be generating a lot of revenue safely with legitimate 503A meds. So that's that cost calculator is really cool at that QR code. And of course, email Katya at MedBioInstitute.com for interest in their support that they provide. So yeah, lots of questions, Coop. So thank you very much. And I'll start reading them off to you. So a lot of them, and I'll just try to address this because several of them dealt with the same topic, and so I'll just address all of them at once. Some of these peptides like BPC 157 or TB 500, somebody mentioned that they're on a Category 2 list from the FDA, which means the safety is not clear and they may or may not be able to be compounded. So that's actually something that's pretty cool. With the 503A pharmacies we're working with their legal team, and the fact that these are not research grade, the fact that they're getting these from FDA registered manufacturers that are on a green list, I mean, all these different levels of legitimacy, that the other reason that they are offering these medications through a 503A pharmacy through us is because they have seen where an actual press release where the FDA is actually going to be officially moving these items off the Category 2 list. So in the meantime, it appears that they are not. There's no enforcement activity with the with those being on the Category 2 list, because their intention is to move these peptides, specifically the ones we've mentioned, moving them off the Category 2 list. So if you want to wait until they're officially off the Category 2 list, no problem. If you want to discuss with your lawyer, no problem. But the 503A pharmacies that we're using, again, not research grade material from research grade labs that say on their website, not meant for human use. Those 503A pharmacies that are getting these meds from green listed FDA registered manufacturers, that their communications with the FDA are that these are going to be moved off the Category 2 list. And the approach that they are taking is that there will not be any enforcement actions with those 503A pharmacies in the meantime. I believe in my own practice, I'm in the trenches with the rest of y'all with my own practice, that I'm comfortable offering these through from a 503A pharmacy, because if there is any liability, that I'm getting it from a 503A pharmacy. If I was getting it from a research lab, then I have no leg to stand on. So everybody's got their own approach that they want to take as far as their risk mitigation strategies and what they're comfortable with, what their risk tolerance is. I'm not here to change anybody's mind, but that is the insider information that we have, is that the FDA is moving these off the Category 2 list. And in the meantime, 503A pharmacies that we're working with are comfortable offering them. So that really is kind of a blanket statement for a lot of the questions. The other question is, somebody asked if this will be available after. Yes, this will be available as a recording. You'll be able to get this this will get automatically emailed to you about 2 hours after the conclusion of the webinar. This next question, and Coop, you can provide any feedback if you want, but they're asking about any contraindications with cardiovascular disease or non-ST elevation MIs. Coop may have some additional information she wants to provide, but any of the peptides that she was mentioning that can cause fluid retention, that's probably something that you don't want to affect somebody's blood pressure or the strain on their heart in those situations. So that seems like a pretty clear-cut indication. So it sounds like the CJC ipamorelin can cause fluid retention. Some of the other medications you mentioned can cause fluid retention, so you probably wouldn't want to use those in cardiovascular disease. Coop, do you have any, can you rattle off some of the other ones that cause fluid retention that you mentioned?
Well, yeah, I think basically, yeah, any of the ones that have a fluid retention as a side effect, you're going to want to use with caution in that type of patient. And if they're a well-controlled, they're on a medication, their blood pressure is well controlled, it's going to be a case by case, certainly.
So then the next question going down is Glow. Let's see. Can you talk more about the cycles that are 5 days on and 2 days off versus 8 weeks on and 2 weeks off? For example, what determines one versus the other, really?
So some of them are recommended to be a daily injection. Some of them are recommended to be 3 times a week, and some of them are Monday through Friday with Friday, Saturday off. And that's the dosing schedule. And you'd want to follow that dosing schedule for 4 to 8 weeks, and then take, usually the recommendation is 4 weeks off, just to give those receptors a break, and then come back on with that same dosing schedule again.
And I think sometimes it also has to do with compliance and patient preference. The thing that we also have to remember is that, kind of going along with a lot of the questions people are asking about peptides and how you can get it from a 503A pharmacy, is that a lot of these peptides have not been through the same rigorous testing that we're used to with GLP-1s or any medication that the FDA has approved. So you have to understand there is going to be some disparity between very clear-cut recommended guidelines on the medication. So that's why we're providing you with some generally accepted guidelines. But as far as having this very clear-cut, Big Pharma spent $1 billion on multiple clinical trials to figure out exactly the regimen you should try. You're not going to find that here. So you have to just recognize the difference in what you're willing to accept as far as guidance. And we're trying to provide you with the best guidance possible. Patients may come to you with different views on what they've heard or read online. And I think a lot of times we should all try these medications ourselves and see what we feel like is working best. So for me, for example, with NAD, I use it 30 minutes before I go work out. And I feel like it provides me with a higher level of stamina throughout my workout. And that's how I choose to do it. And I don't use NAD on the days I'm not working out. So the next question here is for the topical creams for the scalp for hair growth. Do you put the topical right on the scalp for hair growth? If you want to provide some more background on Coop. But as far as the sprays that we offer, that yes, we're putting them directly on the scalp. And then there are some of those sprays have oral versions, of course, as well.
Yeah, exactly right. And there's creams versus sprays. So yeah, you apply directly to the scalp and comb through. You definitely want it on the skin, not just in the hair.
What about this provider has a number of patients with hair loss after chemotherapy. What would you give someone with a history of cancer?
With that, you could look at the Hair Force 1. You could look at a few of the different hair formulas. And I would definitely want to get input from their oncologist if I had any questions about, is something safe or not.
Yeah, and that's, I agree with you. This has less to do with what we're referring to as peptides today. Hair Force 1 is really just high dose vitamins and biotin. In most cases, that's going to be fine. And then also you can do cedar, which is biotin, minoxidil, and finasteride. You wouldn't want to use that in somebody that's a premenopausal woman. The finasteride, we have cedar for women without the finasteride. There's willow that doesn't have finasteride, it has spironolactone instead. So I think there's a lot of non-peptide, or what we're referring to as peptides. There are a lot of non-peptide options for hair loss, especially after chemotherapy. And quite frankly, a lot of that hair will come back after they stop the chemotherapy. This is another question about the peptides and whether they're helpful with people with hereditary Ehlers-Danlos syndrome. And I'll take this just because I've got a little bit of additional information about it, is that's similar to kind of the cardiovascular question about fluid retention, that some of these peptides that we talked about with fluid retention, that can affect cartilage and joints and can cause additional issues in hereditary Ehlers-Danlos. But in general, if it's not causing fluid retention, that's actually okay. Let's see here. There's a patient with chronic injury pathology, spinal stenosis, shoulder issues, but who is very active in the gym. Can they cycle Wolverine for eternity, or is there a limit?
As far as I'm aware, it's meant to be cycled kind of indefinitely until improvement is seen. And if there's somebody with a chronic condition, that may be indefinitely.
I agree. Let's see. When we are clearing patients for these peptide treatments, are there any other contraindications for these aside from cancer? Where can we find specifics on how to work with patients, work makeup to make sure they're a good candidate? I think, if you don't mind, I just want to say that you mentioned cancer, and everybody is worried about cancer, obviously, just in general. There is not really good evidence that any of these are causing cancer. And as I've said on a recent TikTok, if you've got metastatic cancer and you're worried about taking these medications are probably not what's going to kill you if you have metastatic disease. These medications, these peptides have a place when there's no history of cancer. Maybe they don't have a place when there is a history of cancer, just kind of like estrogen. Estrogen is an amazing medication for women who are going through menopause. However, if you've had a history of breast cancer, you may not want to take estrogen replacement therapy. So all of these things have a place and have a role. But when it comes to cancer, there really is not good evidence that these are causing cancer, certainly, or should they not be used in cancer? I think we just, because somebody's brought up the risk of cancer, you don't use it with a history of cancer just in an overabundance of caution. But the reason they're making these associations, and I want to be very clear about this, is that some cancers express a lot of TB4, thymosin beta. A lot of cancers express thymosin beta, which can be involved in cellular repair. So yes, cancers do express that. So thymosin beta, also the more commercially available version of that is TB500. So saying that something is expressing a lot of TB4, thymosin beta, is not the same thing as you give somebody TB500, that's going to cause cancer. That's not really a cause and effect relationship. Also, in cancer, there's overexpression of these receptors, but it's not saying that there's nothing to suggest that you giving therapeutic doses of TB500 is going to lead to cancer. So I really want to caution everybody that we still have to stick to what science we do have. And just because there's an overexpression of that doesn't mean you taking it is going to lead to cancer. The other thing to think about is like with NAD, the reason they think that NAD is helpful for energy is that we have clinical evidence that people's NAD levels can drop by 50% as they get older, after they get over the age of 40. And so the idea is, okay, your NAD levels have dropped, we'll provide you with replacement NAD to give you more energy. But there's also questions of whether the NAD levels dropping is really leading to your feeling of lethargy. I would argue, though, if you are feeling like the NAD is helping you, and even if it's a placebo effect, I think it's still worthwhile taking it, especially, I really feel like it makes a difference. I feel like Wolverine blend makes a difference in my stretching routine before I work out. I feel like I stay more limber. So these are all very personalized experiences that people are having. And I think that, the concern about whether there's cancer or not, if there's a history of cancer, then yes, you probably shouldn't use it just because that is a topic that has been brought up. But I think as more data comes out, we may find that there is really no relationship with cancer. I'm not saying that's going to be a guarantee. I'm just saying that as you get more data, you learn more and you adjust your recommendations based on that. What lab work you were talking about lab work, I think with sirolimus or rapamycin. What lab work are you recommending for that?
Just kind of basic CBC, CMP, TSH, just to get a baseline, and lipids, and because there is potential for some transient hyperlipidemia with it. So just get a baseline, check it again, maybe 4 to 8 weeks into therapy, and then as needed from then on. Right.
Yeah, I definitely think, and most patients probably already have the lab work for you. Another question is preference between sub-Q or nasal Sermorelin.
I usually leave it up to patient preference. If they're already on injectable, they may not want to do an additional injection, or they really like doing their injections, so they feel like it's more efficacious, or they're actually doing something. So I typically leave it up to the patients, but if they're already doing an injection, they may not want to add to that. So nasal spray is a nice, alternative.
And the other preference I've heard from patients, and I do believe they're both as efficacious as the other, but I do also hear from patients that Sermorelin injection, which can be a daily injection, that it burns, and so that's why they choose not to do that, and that's why they prefer nasal. And also, depending on your state, it's sometimes easier to get nasal preparations than injectable preparations. Depending on the compounding pharmacy we use, within DrWell, certain states might not have injectable from this pharmacy, but we can still get the injectable from a different pharmacy. But if you're just worried about availability, then you can always go with the nasal preparation, since that's not considered as sterile a product as an injection. This person's asking, is Sermorelin linked to limited to a 2 to 3 month cycle?
No, you don't have to. It is recommended to take drug holidays on occasion. So it's something that you can do. Take a month off and then come back onto it. Certainly.
And then somebody's asking about troches for that pricing. I think they may be referring to the PT 141. You think they didn't specify in the question? This is how many troches for that pricing? Evidence that one route is better than another. Let's just say they're talking about PT 141. That you mentioning there were troches for that.
Yeah, I'm not sure. I'd have to double check. I would assume it's the 30-day supply, but I don't want to give incorrect info.
Yeah. Yeah, if that's what we're talking about, it was a 30-day supply. Yeah, or at least let's see, and then you have okay, continuing on. Yeah, this is the question about the labs for sirolimus. A lot of those is always struggling. This is a question about PT141 as far as starting low, increasing to the desired effect. Any input on that?
Yeah, you definitely want to start low with it, and then you can increase. I believe the max recommended dose is like 40 milligrams for the injectable. So yeah, start low, increase as tolerated, and based on effect and side effect.
Yeah, I mean, a lot of this is definitely patient experience. It really is.
Mm-hmm.
Again, another thing that people are not used to, they expect their doctor just to tell them exactly what to take. And that's even true with GLP-1s. We were going with that regimen, the commercially available regimen, but we're finding that patients really give you the feedback when they feel like they've hit their goal weight. Then they are backing off and they're saying, you know what, I think I can get away with 3 shots a month or 2 shots a month. And it's really, that's why this is all really personalized medicine, because these medications are conducive to you taking a different regimen that may work for you. So it's and I feel like people want more certainty to that, but that's also a good thing that it allows for more personalization for the patient. Can you, this NAD injections, do any input on IM versus sub-Q?
I like to do sub-Q, especially if they're doing it at home. It's a little less invasive, a little less painful. And I feel like it carries through because it's being absorbed and distributed a little more slowly, a little more steady state, as opposed to the IM route.
And certainly it's less painful with the sub-Q versus the IM route. Does the recommended location for the sub-Q injection, is it typically just abdomen, thigh, or arm?
Yep, anywhere you can pinch an inch, abdomen, thigh, back of the arm, most common.
All right, continuing on, let's see. Let's see here. Now these are good questions, but there's some of them are repeats, so I'm just going through them here. Let's see. Should you evaluate your patient's hormone levels prior to beginning peptides? It is my understanding that peptide results more effective when hormone levels are within normal levels.
So, I mean, if you're planning on, replacing or dealing with their hormones, that would be a consideration. But across the board, no, I'm not gonna, unless they are interested in having hormone therapy, I don't feel it's necessary. But they will definitely have better results overall if everything is optimized. But if you're not the one that's going to be dealing with that, then it's kind of extraneous information for you.
I agree. No, good point. Is NAD as effective in the oral form as it is in the injected form? And in the partner pharmacies we work with, they would say it is. I hate to say it, but with some of these medications, if you get the same side effects with the oral version versus the injected version, it probably has the same efficacy. I've tried the NAD, the oral version of that, and it's you get a little nausea from it, just the way you do from an NAD injection. I feel like I get a great workout from it as well. So, but whether the depth of information as far as the bioavailability, I think we'll keep in mind also with these oral versions of NAD specifically, they are sublingual. Well, I shouldn't say they're sublingual. It can be a large tablet, and maybe it's hard to put it all under your tongue, but they all are absorbed through the mouth. So they're definitely meant to be absorbed through the buccal mucosa. Are the non-physician model class, so I think we're talking about nurse practitioners offering these peptides through their telemedicine. I think you were saying they are, but I want to be sure. Yeah, no, all of our providers are nurse practitioners, PAs, physicians, cardiologists, plastic surgeons, dermatologists, colorectal surgeons, really every field of medicine, every level of training are offering these. And that's actually a good time to mention this, that DrWell offers, if you're a nurse practitioner, PA looking for in a state that requires a medical director, DrWell can offer that for you. That amongst all of our providers, we're licensed in all 50 states plus DC. So if you are looking for a medical director to run a weight and wellness program through DrWell, we're not talking about medical director to do Botox injections or laser hair removal. We're talking about through anything that's offered through DrWell, as far as medications, that you can reach out to us, take a picture of this QR code. We can give you more information about our medical director opportunity, that we can offer you a medical director and help you with all the legal paperwork. Obviously that costs something, but we can, but the benefit is that you don't have to go find a medical director, and you don't have to figure out who's going to write up your legal documentation. We'll be using somebody that does this all the time, so we'll know that it's an airtight agreement to protect both parties involved. But yes, all medical providers are offering these peptides. Let's continue on. Let's see. Pre-op recommendations or post-op recommendations. The experience. So visual changes with GLP-1s. Patients may say that they're getting blurry vision for something. I don't know if I don't have enough history with each patient that I'm hearing about that from TikTok. But just in general, just to be clear, the patients get worse vision when their sugars are corrected. If they have diabetes and they get on whatever medication, insulin or oral anti-diabetes medications, their vision actually can worsen when they get their sugars under more control. And that can be diabetic retinopathy. That's a known thing. They don't exactly know why your sugars improve. There's multiple theories, but that's a known thing, that they can get worse vision when they correct their sugars. Similarly, the thing that's come out about NION, which is non-arteritic anterior ischemic ophthalmic neuropathy, NION, which can cause blindness. It's sort of like a stroke of the eye. That can be associated with GLP-1s, is what the reports are coming out. But it's really kind of similar, analogous to diabetic retinopathy. It could be because of corrections of sugars. The other thing we have to really keep in mind here is, even though it gets it's like really incendiary and it gets a lot of press on traditional media and social media, is that the risk of NION, again, the non-arteritic anterior ischemic ophthalmic neuropathy, that NION is about a 0.2% risk over 20 years in type 2 diabetics. And with in the clinics that mostly see that, they were associating that with GLP-1s, but that may be a confounding variable. It's selection bias, that's the kind of patients you're seeing, and everybody's on a GLP-1 now. But the risk looks like it increased to 0.3 or 0.4% from 0.2% over 20 years with type 2 diabetics. So I think it's a very low risk as far as that's what I wanted to say about vision changes. The next question, does DrWell offer a GLP-1 pill? Yes, we have pills, we have troches. Our compounding pharmacy providers offer it in those different forms, absolutely. Let's see here, a lot of questions. Wow, I'm just trying to get through them. Patient travels frequently a good amount of time. What would be the best method for traveling with these peptides? So as far as traveling with any of these peptides, GLP-1s, and they travel a lot and they need to be refrigerated. So with the GLP-1 specifically with our pharmacies, say that they can withstand heat up to 220 degrees over 72 hours. So that's very rare that's going to happen. So what I would say, and what we tell our patients, is if they are traveling with BPC 157 or any of these peptides that need to be refrigerated, or GLP-1s, that they can travel. We actually have these carrying cases that are insulated. They can put ice packs in. They can travel, even if they weren't in a cool pack while they were traveling, and they just put it in a fridge whenever they get to their destination. That's totally reasonable. Okay, we mentioned about let's see, do your peptides come mixed and ready to use? Oh yeah, this is a great question. Coop, I'll let you take that away. Do they come pre-mixed, or do they come in a powder form?
Yeah, no, the powdered form is the research grade, and it gets sent to you and you have to mix it yourself. The 503As pre-constitute this. They are ready for injection upon receipt.
That's a big red flag. I mean, again, Coop mentioned it. I mean, you're really risking your license when you're offering these research grade peptides from a lab. And some of you are asking about the legality of getting these from a 503A pharmacy. Again, it's risk tolerance. You can either get it from a lab or you can get it from a 503A pharmacy. And that's a big red flag. If it comes as a powder, it's a lab. It's not a 503A pharmacy. A 503A pharmacy mixes it under a sterile hood, as opposed to having your patients mixing it themselves in their kitchen. Let's see, continuing on. Do you put BPC 157 or Wolverine directly into the injury site or belly, or what location is best? I have an opinion on this, but go ahead. You can go first.
Yeah, so there's kind of mixed feedback on that. I have heard where TB500 in particular is recommended to be injected close to the location of injury. Ultimately, it's being absorbed systemically. So I say sub-Q. Like, I'm not going to inject it directly into my toe where I had surgery, because that sounds awful to me.
I was thinking the same thing. I've definitely heard of people who had like biceps tendon injury and things like that, and they were injecting directly into the site, and more power to you if you can tolerate it. And they swore by it that it worked better that way. But yeah, that was the first thing I thought, is how painful it must be to inject directly into the injury site. So this is a good question. Is weight loss faster, or at least faster, better, depending on how you want to phrase it, when combining with hormone replacement therapy and peptides?
Ultimately, you know, if you can optimize everything at once, yeah, they will have the best results. But that's going to be patient dependent on, you know, what their goals are, and if, you know, and the provider's level of comfort with dealing with all of those aspects. But if you're able to optimize all of those things in one go, yeah, I imagine they're going to have the best outcome.
Yeah, there's even evidence that there was one article that I talked about recently that, yes, you definitely want to optimize everything, but they were showing that people who actually were using GLP-1s, that it was actually with their weight loss, it was actually correcting some hormonal imbalance that they had. So that's another way to look at it too. But certainly, if the GLP-1 alone isn't correcting their hormone balance, they definitely should be optimized for their hormone perspective, and everything will work better. All righty. Oh yeah, and then there's the question about pre-op recommendations of GLP-1s.
As far as when to stop them?
Right.
Yeah, typically the recommendation is going to be 1 week or 2 weeks prior to surgery to hold, you know, 1 to 2 doses. We tend to leave it up to our anesthesiologist. We've got one that says 1 week, we've got one that says 2 weeks. So kind of leave it up to anesthesia. But the whole idea behind it is that because it's slowing your gastric emptying, that you're higher risk of aspiration during intubation. So we just want you to make sure, you know, you're holding at least 1 dose so that you've got a good empty stomach prior to surgery.
Right, and I do think this is a little bit of a moving target, and also logistically, it may not really be that complicated to adhere to one recommendation of being off for a week ahead of time. If you take your medication on a Monday and then your surgery is next Monday, 1 week later, then you've technically been off of it for a week, and then you can just pick right back up. So it may not even require you, so you could be off for a week and still be compliant, and, you know, not really skip a dose is what I'm trying to say. The other thing is that some more recent recommendations are coming out is that they're giving the patient the option of also not just being NPO after midnight, but being on a liquid diet, clear liquid diet for the 24 hours before surgery, and not even changing up their GLP-1 dosing regimen. So just have to be honest that this is a moving target, and I don't think it's as difficult to adjust their dosing as we once believed, 1 or even 2 years ago. So that's the last question. I appreciate everybody's attention. These are great questions, very engaging. Again, you'll all get a copy of this recording in 2 hours. Katya, thank you so much. Please email her at katya@medbioinstitute.com. Sorry, I didn't mean to talk over you while I was thanking you. But Coop, thanks so much for the great session. This is what we're looking for. We're looking for kind of the best practices. We're looking for pricing information. We're looking about like business recommendations as far as bundling and how you can benefit from all of this. And your patients can, more importantly, your patients can benefit from this. But yeah, scan the QR code, reach out to Katya if you have any questions. But thank you all again, and we appreciate your time, and we will see you next time.